Welcome to this technical exploration of infection control in the operating theater, where we move beyond simple checklists toward a philosophy of precision engineering. This framework is designed for surgical teams and infection control committees to mitigate the primary driver of postoperative morbidity, healthcare-associated infections, specifically surgical site infections, SSIs. By conceptualizing the theater through macro, meso, and micro zones of control, we can architect a defense-in-depth strategy that protects the incision interface from every possible angle. Slide 2. The defense-in-depth framework. Our strategy relies on three distinct layers of protection. Zone 1, macro, which focuses on environmental engineering of the room's air and physical structure. Zone 2, meso, which addresses provider bioburden through hand preparation and choreographed PPE sequencing, and Zone 3, micro, which involves precise chemical barrier preparation at the exact site of the surgical incision. This layered approach ensures that if one defense is breached, others remain in place to prevent pathogens from reaching the target incision interface. No single intervention provides 100% protection, making the interdependence of these zones critical for success. Slide 3. Zone 1. Structural airflow and pressure gradients. In the macro environment, we utilize rapid filtration systems that strictly adhere to air changes per hour, ACH minimums, often greater than or equal to 12 in protective environments, to continuously dilute and remove aerosolized pathogens. To prevent the infiltration of contaminated air from adjacent spaces, the OT must maintain a consistent positive air pressure differential of more than 2.5 pascals. This creates clear zones where air flows unidirectionally from the cleanest area, the surgical table, out toward less clean areas, effectively sweeping contaminants toward the exhaust. Slide 4. Ventilation showdown, conventional versus laminar flow. Clinicians must distinguish between conventional ventilation, which relies on mixed or turbulent flow to dilute dirty air, and laminar airflow, which uses unidirectional fresh air for total physical displacement of contaminants. While laminar flow is highly efficient, it requires strict temperature monitoring to prevent systemic hypothermia from continuous cooling. It is important to note that the WHO does not currently support the use of laminar flow specifically for arthroplasty surgery, due to a lack of evidence in preventing SSIs in that context. Slide 5. Zone 2. Eliminating provider bioburden. The objective of surgical hand preparation is to surpass routine hygiene by completely eliminating transient flora from the superficial skin and significantly reducing resident flora located on the stratum corneum. Transient flora are highly pathogenic but easily removed, whereas resident flora are more difficult to dislodge, requiring vigorous mechanical scrubbing or chemical reduction. This process must be performed strictly inside the OT immediately prior to donning sterile gloves and between every consecutive surgery. Slide 6. Surgical hand preparation, scrubbing versus rubbing. Two primary methods exist for surgical hand preparation: scrubbing with antimicrobial soaps like 4% CHG or povidone iodine for 2 to 5 minutes, and rubbing with an alcohol-based hand rub, ABHR, for 3 minutes. Scrubbing relies on mechanical action combined with antimicrobial agents, while ABHR utilizes rapid protein denaturation via 60 to 80% alcohol solutions. According to the WHO, both methods are equally effective at reducing SSIs, provided that methods are not combined sequentially. Hands must be completely dry before applying a rub to prevent dilution and skin irritation. Slide 7. The choreography of protection, PPE. The effectiveness of personal protective equipment, PPE, relies entirely on strict spatial and temporal sequencing during donning and doffing. For further protection, routine double gloving is heavily recommended to prevent sharp injuries, as statistics show that roughly 18% of gloves possess microscopic punctures after surgery that often go unnoticed by the provider. While organizations like IDSA and SHEA firmly recommend this practice, clinicians should be aware that the WHO currently lacks sufficient evidence to issue a rigid mandate. Slide 8. Sequence I. Donning, building the barrier. Donning follows a specific 5-step sequence to build a sterile barrier. It begins with foundational hand hygiene before touching any clean equipment. Next, the gown is applied to fully cover the torso and arms to the wrists, followed by a mask or respiratory device secured tightly at the middle of the head and neck. Eye protection, such as goggles or a face shield, is then placed to protect mucous membranes. And the process concludes by extending sterile gloves over the gown cuffs to completely cover the wrists. Slide 9. Sequence 2. Doffing, stripping contaminants. Doffing is a critical phase designed to strip contaminants without causing self-infection, starting with the removal of gloves, the most contaminated item, by turning them inside out. Goggles or face shields are removed safely by handling only the clean headband, followed by unfastening the gown and rolling it into a bundle away from the body. The mask or respirator is removed by the straps without touching the contaminated front surface. Finally, hand hygiene is the absolute, non-negotiable step to neutralize any accidental biological transfer that may have occurred during the stripping process. Slide 10. Zone 3. Patient site preparation. Patient site preparation aims to fundamentally reduce the microbial load on the patient's intact skin to the lowest possible denominator immediately prior to the incision. This precise chemical intervention is functionally distinct from routine preoperative bathing on the ward and must be performed strictly inside the operating theater. This creates the final microzone of control, ensuring the incision interface is as sterile as possible at the moment of first contact. Slide 11. The chemical target, efficacy, and constraints. Alcohol-based chlorhexidine, CHG, is the primary WHO recommendation for site preparation due to its rapid and persistent microbial reduction. However, care must be taken to ensure alcohol solutions do not pool underneath sterile drapes, as they are highly inflammable and must dry completely before the procedure begins. Additionally, CHG has severe contraindications. It must never come into contact with the mucosa, brain, meninges, eyes, or middle ear. Slide 12. The aseptic interlock. The aseptic interlock concept illustrates that no single intervention provides total protection. If the laminar flow fails, hand flora isn't neutralized, or antiseptics pool improperly, the entire sterile blueprint collapses. Absolute adherence to every interdependent layer, macro, meso, and micro, is the only statistical defense we have against multidrug-resistant escape pathogens. Success is found in the flawless execution of these connected gears of defense. Slide 13. Precision asepsis achieved. In conclusion, infection control in the operating theater is not a matter of routine checklist compliance, but a matter of uncompromising precision engineering. From maintaining the exact pressure differentials to enforcing the required hand exposure times and non-pooling antiseptic applications, every detail counts. Our ultimate shield against healthcare-associated infections is the flawless, standardized execution across all 3 zones of control.